Do colonoscopies save lives? Do mammograms save lives? Do statins save lives? Those three questions. Colonoscopies, mammograms, and statins.
Okay, you want to say screening colonoscopies and screening mammograms. That means examining people who have no symptomatology. You want to qualify what you're saying, and the answer is absolutely not. As statins, the same thing. It's people who are treated for purely for blood levels and not for post MI. Perhaps it does save lives, and maybe in the very rare hereditary hypercholesterolemia there is some indication, some small statistical improvement. But those all the things you mentioned, in my view, from my reading, are completely ineffective.
So I don't know enough about colonoscopy or what was the other one? Mammograms. That's not my field, but I do know about statins. And I agree with you, Dr. Yoho. In fact, the paper just came out a week ago, very large, hundreds of thousands of patients looking at both primary prevention of MI with statins and secondary prevention of MI with statins. And bottom line is a 1.3% improvement in lifespan, which is basically zero with primary prevention. With secondary prevention, these are patients who've already declared themselves at risk. And there is a benefit for secondary prevention once you've already had an MI, using a statin to try to reduce the incidence of a second MI. But for primary prevention, actually, turns out no benefit, appreciable benefit. The mean increase in lifespan is 4 days, 44 different studies, 44 different studies. Dubroff et al. You can look at Evidence-Based Medicine 2017. And 20% of patients who are treated with statins for primary prevention get hyperglycemia, glucose intolerance, and or diabetes because they are mitochondrial toxins.
With mammography, there was and I think it was Peter Gertcher that you've all referred to that did.
He wrote a book about it.
Yeah, and I think he did the Cochrane review of mammography, and it's just a good example of something that's just assumed to help. Like, how could it not help? It's when you get told you can have a screening test, and whether it's mammography or thyroid screening or whatever it is, and it will detect if you've got a cancer or not, and it could pick it up before it gets harmful, and we could get it out early. It just sounds really good. But when you put it to the test, so in mammography, they've done it with hundreds of thousands of people where they've randomized them to either having routine mammography or not. They've found that the benefit to it is, in some studies, zero, in some studies, marginal to whether or not you live or die. In other words, your life expectancy. And a classic example of how screening can actually be harmful came from South Korea, where a while back they introduced screening because they thought, well, we want to pick up all these diseases. We want to help people. We want to improve the health of society. And one of the things they started screening for was thyroid cancer. And this became big business because the doctors who owned the ultrasound clinic where they did the tests, they were getting paid, and they were picking up a lot of thyroid cancer. Now, it just so happens that a lot of us, a lot of people on this call probably have thyroid cancer. There's a type of thyroid cancer called papillary, which is just very common, and it usually doesn't kill you. But they were picking it up. And so they were referring people to surgery. People were having their thyroid taken out. Now, there's big problems with that. If you don't have a thyroid, you don't have thyroid hormones. So you're on lifetime replacement. There's some very important glands that lie behind the thyroid called the parathyroids. You lose them, you're in huge trouble, and you're on lifetime replacement of another drug. A certain percent, or 1 or 2% of cases, when they take out the thyroid, they take out a nerve that goes to your vocal cords, and so you can't speak anymore. And so, and every now and then someone will die from this surgery. So quickly in South Korea, thyroid went from being a not very common cancer to being the most diagnosed cancer in the country. Incredible harms were done. People were on lifetime replacement therapy. They're having surgery. They're losing their voices, and many people died as a result of this. And then after many years of all this screening, of diagnosing so many cases early, they looked at the trend in deaths from thyroid cancer, and it was a straight line. It didn't move. They didn't save any lives at all, because the severe forms of thyroid cancer were going to kill you anyway. And they were just picking up these benign forms and operating on people and causing harm. So they've had to walk this back and try and reverse this, but it became such an industry. People were making money from the hospitals, from the surgeons, the GPs, the scanners, the drug replacements. It was just this huge industry that was very difficult to walk back. And one of the reasons it was difficult to walk back is because it sounds so good. It just makes sense to people. So it's very difficult to describe to people. Having a mammography may not actually help you.
It leads to a cascade of medical services that often include complications and other problems. John Ioannidis said that basically he didn't think that any screening test was improved mortality. And melanoma is a classic example, identical to your thyroid cancer story. The dermatologists were sort of losing traction about 30 or 40 years ago, and they engaged a Madison Avenue marketing firm to say what to do. And they all said that they should become fierce cancer fighters instead of pimple poppers. So they started publicizing melanoma and how they had to save the world from melanoma and do total skin exams and this and that. And exactly the same thing occurred. The total amount of diagnoses went crazy, but the mortality curve was absolutely flat or nearly flat. So melanoma is not increasing. It's a misconception based on the marketing schemes of the dermatologists.
I want to go back for a sec and pick up on what Dr. Lustig was saying about statins. When you look at whether the question is often asked, should I take a statin? Should I not take a statin? And that's the wrong question. The question is, what's the likelihood that a statin will prevent you from dying or prevent you from having a cardiovascular event? And if you put all the studies together, for people who so-called secondary prevention, for people who already have cardiovascular disease, you have to treat 30 people for 5 years to prevent one a heart attack or stroke, and the other 29 people won't benefit. And you have to treat 80 of those people for 5 years to prevent a death. So the number needed to treat is 80, the number needed to treat is 80 to prevent a death, 79 won't have a death benefit, 30 to prevent a cardiovascular event. That's not a yes-no fact. People should talk to their doctors about that. And as a former family doc, having some idea of those numbers, I felt that I should tell people the numbers, ask them what they wanted to do. If they wanted to take the drugs, say there may be side effects, so come back if there are side effects, but that it's not my decision. If people said, Doc, I'm not a number person, what should I do? I said, well, there is some benefit if you want to try it and see how you do. For primary prevention, there is not a significant death benefit. And according to the current guidelines in the United States, people who have between 7.5% risk and 20% risk of developing a cardiovascular event over the next 10 years should be on a statin. You have to treat 100 of those people for 5 years with a statin in order to prevent one non-fatal heart attack or stroke.
500 patient years.
Yes, 500 patient years.
It's ridiculous.
People can draw their own conclusion. I'm not saying yes or no, but I think it's essential that we explain what the data shows about what the benefits are and aren't, and let people participate in that decision.
Well, let me weigh in on that too. The reason that statins are so complicated is because we're looking at one primary surrogate endpoint called LDL. And LDL is not one thing, it's two. There's one called large buoyant and there's one called small dense. Turns out the large buoyant LDL is cardiovascularly neutral. It's large, it doesn't get under the surface of the endothelial cell to start the foam cell plaque formation process, and it's buoyant. It's carried via laminar flow through the capillaries and through the arterioles. So it doesn't have an opportunity to set up, and it also tends not to oxidize because it's oxidized LDL. That's the big problem because it's larger. Small dense is the bad guy in the story. They're small, they do get under the surface, they're dense, they don't float, and they oxidize much more easily. Turns out statins only treat the large buoyant. They're working at the level of the liver to reduce the large buoyant. It's the small dense that matters, but the large buoyant is 80% of what's in the bloodstream. So basically, it will reduce your LDL level, but that's the wrong surrogate measure. If you were looking at a surrogate measure, small dense would be a good one, and there you don't see any effect. And that's one of the reasons why you don't see any improvement in cardiovascular risk ratio or mortality in those patients. So if you look at people who've already declared themselves in secondary, then there again seems to be a benefit because they've already declared themselves.
Well, Dr. Abramson, can't you decide on the basis of 500 patient years of treatment of this? It's not a very toxic drug, the statins, not compared to a lot of other things we know about, but 500 patient years to treat to prevent one non-fatal heart attack. I mean, how many patients have the skills to make a decision like that? And if you're not sure, how can they be sure?
Well, we can't make the decision for them. I mean, no therapy is 100% effective or zero, or not many are 0% effective. It's always shades of gray. And I think we've got to bring patients in and give them the best information we've got.
Well, it's a little like the urologist trying to counsel about radical prostatectomy. 25% of them get impotent, 25% get incontinent, and 25% had the cancer metastatic already. And the urologist has enormous conflict of interest, right? He gets to make all the money, and he's disappointed if he can't do the surgery. So they got a hammer and a nail, and that's all they see. So I mean, look, the decision seems simple to me, and I was willing before I retired to help my patients understand the math, and 500 patient years for the potential problems that is. I mean, how many people could get through 500 patient years without having some horrible complication with a statin? I mean, the chances are it's a pretty clear balancing thing, to me. But maybe to you, you see things in a lot more detail because maybe you're brighter than I am. But I sort of see things in, does the patient go upstairs and get admitted, or do they go back out on the street? I'm originally an emergency physician. It's binary almost. And what is the bottom line with 500 patient years of taking a statin? I wouldn't want to take one for 20 years, let alone 500 patients.
Right. And I think the most important takeaway message for the doctor-patient discussion is that the evidence is pretty strong that the conversation ought to be about getting exercise and eating a healthy diet. I mean, we talk about statins as an end in itself, and it's not. The goal of taking statins is to decrease your risk of cardiovascular disease. And if we wanted to have a conversation about cardiovascular disease, then the first subject, and probably the second, third, and fourth, would be how to take matters into your own hands and live a healthy lifestyle. And then maybe in the fifth place, maybe people would want to have a conversation about whether or not to take statins.
I want to hear what Dr. Lustig has to say about saturated fats.
Saturated fat is not the cause of cardiovascular disease.
It's a good thing, right?
Insulin resistance is the cause of cardiovascular disease. So red meat, it's all about red meat, okay? So the studies say that red meat increases risk of cardiovascular disease. And that's true. The hazard risk ratio for high red meat consumption is 1.25. Now, public health experts say you have to have a hazard risk ratio of 1.3 or greater to be a public health issue. But 1.25, I mean, it's still there, it's still significant. However, it's not about the saturated fat. If you control for the heme, the branched chain amino acids, and the trimethylamine oxide, TMAO, that comes from metabolism of choline by the microbiome from red meat, because red meat's very high in choline, the hazard risk ratio goes from 1.25 down to 1.10. So saturated fat's still there. In fact, the PURE study showed that saturated fat was cardiovascularly neutral. It's probably the oxidative stress of the iron. It's probably the insulin resistance from the branched chain amino acids because of the corn-fed beef in America, at least, maybe not in Australia, Dr. Harris, and also the TMAO. So I'm not saying red meat is good. Red meat has a potential problem, but it's not because of the saturated fat. And we equate red meat saturated fat and dairy saturated fat as if they are the same thing. They are not. Red meat saturated fat are even chain fatty acids, C16 and 18, palmitate and stearate. Dairy saturated fat are odd chain fatty acids, C15 and C17, with a specific phospholipid signature that has actually been shown to be protective against cardiovascular disease and diabetes. And when we take the fat out of the diet, the saturated fat out of the diet, we're taking both out. So you're taking out something that's actually protective. So saturated fat is the tempest in the teapot that we got wrong 50 years ago. And, Ansel Keys, may he burn in hell.
So what do you think about the carnivore diets?
It works. I'm not a fan of it. I think there are some things missing, but it does work, and it does seem to improve, certainly improves small dense LDL, which is the bad guy. It increases total LDL because, dietary fat.
Right, but what about mortality and other diseases and all that?
There's a slight improvement in surrogate measures. I don't think anybody's been able to look at mortality. Hasn't gone on long enough.
Yeah.
It's one question about hospitals. We're told that hospitals are nonprofit. That sounds pretty friendly. So I feel like the hospital is certainly, on my side, it's a not-for-profit hospital. They're just trying to help me. Can you tell me what their role is in the medical industry?
So first of all, non-profit hospitals in America, I won't say anything about the rest of the world. Nonprofit hospitals in America are anything but. Okay? All they have to do in order to declare nonprofit status is treat 1% of their patients for free. That's it. Okay? Other than that, they are for-profit. And in fact, they make more money than the for-profit hospitals. And their executives actually have a higher salary than the for-profit hospitals.
There's very little oversight.
There's
they don't have a board.
Oversight.
They don't have a board like for-profits.
I took health law in law school to learn about this, and there is no such thing as a nonprofit hospital.
Hospitals are the second most corrupt part of medical care.
Yeah, our private hospitals in Australia are divided between for-profit companies and non-profit groups. But in speaking to one of the largest non-profit groups about doing research and things, and they wanted to know, I wanted to do a study there, and they wanted to know how much money I was going to give them. And I said, well, this is just research, it's investigator initiated. It's not an industry study. And they said, because there's one thing you need to understand about our organization. We're not for profit, but we're also very much not for loss. And they make money, but they channel it into other things.